Our first speaker is Dr. Manasa. Dr. Manasa is a cataract and glaucoma specialist. She works at PRS and Geetanjali Hospital, Trivandrum. She'll be speaking on the perioperative surprises in cataract surgery.
So good morning, everyone. So while cataract is one of the most performed and has a lot of predictable outcomes in the whole of ophthalmology, the perioperative period can present with unexpected challenges that can test our clinical acumen. So the perioperative period is a time lapse surrounding the surgical act. So this process has many steps in it, and suboptimal completion of one steps can result in error in the next, like a domino effect. It doesn't have an autocorrect mechanism, resulting in a complication or a poor surgical result. So in this presentation, we shall discuss 5 real-world scenarios where this perioperative unexpected challenges are highlighted. So in the first case scenario, so this is about a 72-year-old lady who presented with defective vision in both eye. She had bilateral immature cataract. There was no signs of pseudoexfoliation, sonulopathy, or chronic intraocular inflammation. So cataract surgery was performed in the right eye. Post-operative 1 week, everything was uneventful, good gain in visual acuity was present. At 6 weeks post-op, she is presenting with an uncorrected visual acuity of 6/36. So on examination, she had a total anterior capsular phimosis. So as you can see in this video, this was taken in the mobile phone that was involving the visual axis, which warranted a surgical release because it was not amenable to YAG capsulotomy. So here we have to be aware of the risk factors, like making a small rexus is the most important risk factor, others being pseudoexfoliation, sonulopathy, advanced age, etc. And taking all possible preventive measures like making a large rexus, thorough cleaning of the capsular bag, regarding the choice of IOLs, using CTR, CTS when necessary, and vigilant observation to detect early so that you can do a YAG capsulotomy before it involves the visual axis. And if it involves the visual axis and if it is total surgical correction, and if it's not treated, it can result in IOL dislocation. The second scenario is about a 65-year-old lady who had multiple comorbidities and who presented with defective vision. So on examination, she had a nuclear sclerosis grade 2 with posterior subcapsular cataract and a moderate dry eye disease. So she was treated with liberal lubricant, cyclosporin, and after 6 months, she was posted for cataract surgery. So again, at 1 week follow-up, she had good gain in visual acuity. Everything was looking fine. 6 weeks, she's presenting with complaints of foreign body sensation in the operated eye. So on examination, there was a 2 millimeter linear defect overlying the clear corneal wound with an erosion of the posterior margin of the clear corneal incision, if you can see in the slide. So again, we revisited her systemic history only to know that we missed a history of rheumatoid arthritis. She was a case of rheumatoid arthritis, was taking treatment 10 years back, was not on any treatment for last 10 years, no obvious deformity, so it was missed. So she was treated with liberal lubricants, BCL, was referred to the rheumatologist, started on immunomodulators, the lesion healed in 1 month. So when it comes to OSD, a compromised OSD will interfere in all stages of the surgery, so we have to optimize to get good surgical results. So intra-op considerations like minimizing the surgical trauma, using lesser fluid, liberal OVDs over the cornea, preferring a clear corneal incision, avoiding areas of corneal thinning to be considered. They might require long-term postoperative care and follow-up. The third scenario is of a 75-year-old gentleman, one eye pseudophakic, other eye he's presenting with a dense nuclear sclerosis, a vision of hand movements. So under the microscope, in the OT, I was surprised. Under the microscope, there was absolutely no visibility. There was a lot of glare, low contrast, and why did this happen? The optics and the illumination system of the slit lamp and the operating microscope vary greatly. When it comes to a hazy cornea, the illumination provided by the operating microscope is far inferior to that of a slit lamp. Why? Because the slit lamp illumination is way more adaptable. You can adjust the height, width, the angulation, the illumination of the slit beam to examine the intraocular structures through areas of clearer cornea. Whereas when it comes to the operating microscope, it gives a diffuse illumination, and with all the corneal haze, there is a lot of scatter, decreasing the contrast and increasing glare and poor visibility. What can be done about it? You can ask your assistant to hold the N2 illuminator in the sides of the limbus to give an angular and oblique illumination when you perform rexis. And if the nuclear sclerosis of a lesser intensity, the endoilluminator through a pars plana route also helps. The fourth scenario is of a 55-year-old female who presented with defective vision in both eyes. She was on long-term steroids for ITP. On examination, she had both eye posterior subcapsular cataract with a shallow anterior chamber. Gonioscopy showed occludable angles but less than 180 degrees. She has a family history of glaucoma. IOP was normal. Optic nerve head was healthy. So she was posted for right eye cataract surgery, and 1 week post-op, she's presenting with a best corrected visual acuity of 6/6 but with a -2 diopter surprise. So she had a very shallow AC and an IOP of 30 millimeters of mercury. So in a refractive surprise, first we revisit the biometry. So the pre-op IOL calculations was revisited. The anterior chamber depth pre-op was 2.45 millimeters. Post-operative 1 week, you can see the ASO scan. The anterior chamber depth dropped to 2.3 millimeters. So B scan was done to rule out any suprachoroidal hemorrhage, ciliary body or a choroidal effusion. UBM was not available. She was started on cycloplegics and aqueous suppressants. The IOP at 1 week follow-up, her manifest refraction dropped to -0.25 diopters of sphere, and anterior chamber depth improved to 3.4 millimeters. So YAC PI was done and the patient's manifest refraction was stabilized. So this was a case of aqueous misdirection syndrome, rare, but it's good to know the risk factors. A female with shallow anterior chamber, hyperopic, they are at higher risk. And the last case is of a one-eyed elderly female. So she lost that eye to a trauma. This is cyclical now. So the other eye developed a mature cataract and she was presenting with defective vision. So the normal workup was done, the biometry was done, but the biometry kept on giving inconsistent results, varying from 22.19 millimeters to 24.72 millimeters. A B by A scan was done, some choroidal irregularity was noted, but anyway, the cataract had to be done. So this 24.72 was unfortunately taken, and post-operatively, there comes a +4 diopter surprise. So post-operative fundus examination, you can see a choroidal mass, a lumpy bumpy appearance on the OCT, referred to a higher center, came out to be a case of lymphoma. So again, this is rare, but the message is when it comes to a refractive surprise, an ounce of prevention is worth a pound of cure. So we should anticipate these surprises in extremes of cases and adjust the IOL calculations accordingly. And another option is when we are planning both eyes, you can go for the non-dominant eye first and fine-tune the other eye later. And be aware of the factors that conform the biometry, like an ocular surface disease, and diagnose early and determine the cause. And if we don't find any error in biometry after ruling out all other causes, it might be an error due to any miscalculation of the effective lens position. And management. See, not all patients might be symptomatic with a refractive surprise. It greatly depends on the individual. And if the patient is amenable to spectacle correction, go for it. If the patient has been using contact lenses earlier with a high anisometropia, yes, contact lens is an option, because a second surgery will always have the risk of drop in best corrected visual acuity and increased risk of infections. So, but in patients who want spectacle independence, can consider keratorefractive procedures, an IOL exchange, piggyback IOLs, depending on the scenario. So basically, these are the common surprises that we might encounter. Again, these are uncommon, but when it comes, it's a little unfortunate. So a detailed history and thorough clinical examination is very essential to achieving patient satisfaction after cataract surgery. And we have to identify subtle subclinical conditions, because most of the subclinical things will surface after a surgical stress. Thank you.
Thank you, Dr. Mansa, for highlighting very subtle points which should not be missed in